Hello friends, welcome to this video. So this video is a continuation of a previous video. In a previous video we discussed about the shoulder joint anatomy. Now we are going to discuss about the shoulder dislocation. So which is our case for today. So as you can see, what is shoulder dislocation? It is nothing but the slipping of the head of the humerus from the glenoid cavity. This is called as the shoulder dislocation. And as you can see from this diagram, the normal contour of the shoulder will be lost in case of shoulder dislocation. So let's discuss the types of shoulder dislocation. There are generally three types of shoulder dislocation. Among these, the anterior shoulder dislocation is the most common. About 90% is anterior shoulder dislocation. In case of anterior shoulder dislocation, it can be easily diagnosed just by the presentation or the posture of the patient. The patient comes with slightly flexed and external rotated arm, which is holded by the opposite hand with the help of the opposite hand. This is the typical presentation of an anterior shoulder dislocation. Also, you can see the humeral head which is prominent behind the clavicle. This shows it is a case of anterior shoulder dislocation. This condition is very painful. Dislocation is commonly seen in some players such as cricket or baseball, in which when they forcefully throw the ball, their arm assumes a typical position of abduction and external rotation. So the humeral head tends to slip off from the glenoid cavity. So this is the case of anterior dislocation. And when you see this diagram, this is a case of inferior dislocation. It can be diagnosed with the typical posture of called the salute posture. The patient comes with hyper abducted arm just like this. So with just by looking at the case, you can diagnose it as extremely rare. It is also called as the luxatio erecta. Okay, just it refers to its posture. And again, posterior dislocation, this is also rare, and this can be remembered easily with the help of a mnemonic 3E's. So the posterior dislocation is common in epileptic patients. It is also seen in electric shock victims. And the third is a sign which is called the electric bulb sign. Okay, what do you mean by electric bulb sign? As you can see from this diagram, this posteriorly dislocated head of the humerus appears as if a glowing electric bulb. This is so it is referred to as the electric bulb sign. And also in case of anterior dislocation, the head of the humerus lies beneath the clavicle, just it superimposes the scapula. So this can be easily diagnosed with the help of an X-ray or even clinically. Okay, fine. Next, we are going to see the complications of shoulder dislocation. The most common and the immediate complication is damage to the axillary nerve, which was a question asked in our case. The most common nerve damaged in shoulder dislocation is axillary nerve. And the most common overall complication of shoulder dislocation is recurrence. So recurrence is a very big problem when it comes to shoulder dislocation. So what is the management of shoulder dislocation? The shoulder dislocation can be managed by closed reduction. These three methods, but the method of choice is the modified Coach's technique. This is the method of choice. This one is Simpson's gravity method. This is not followed now. And this is Hippocratic method. This was the oldest method of shoulder dislocation. So just by giving traction with and counter traction with the help of the leg, they reduce the shoulder dislocation previously, but this is not followed now. And in Simpson's gravity method, they used 10 to 15 pound weight, which is made to hung down, tied on the hand, so that it gives a downwards traction and helps to relocate the displaced or the dislocated head of the humerus. But this is also not followed now. The method which is followed is Coach's technique. This can be remembered with the mnemonic TI. Okay, so First, you apply traction along with external rotation so that you pull the dislocated shoulder, anterior shoulder, and place it just near to the glenoid cavity. Then you apply adduction and finally internal rotation. So as you can see from this diagram clearly, it has four components: traction with external rotation, adduction, and internal rotation. So it helps to reduce the dislocated shoulder. And let's see about the recurrent shoulder dislocation. The recurrent shoulder dislocation can be remembered by an easy mnemonic: TUPS and AMBRI. There are two types of recurrent shoulder dislocation. TUPS is generally torn loose. AMBRI is, sorry, I kind of move myself from it. It is bond loose. Okay. So what is torn loose and what is bond loose? So in case of TUPS, T for traumatic. It is a traumatic shoulder dislocation. U stands for unidirectional. It always, for example, when a cricket player dislocates his arm, he always dislocates his same side arm and in the same direction. Therefore, it is unidirectional. Okay. So, what is B stands for? B stands for Pankhurst's lesion. This is because of the dislocation. There is injury to the antero-inferior part of the glenoid labrum. Okay. In turn, because of the injury of this antero-inferior part of the glenoid labrum, there will be recurrent shoulder dislocation. So it is vice versa. And also Hill-Sachs lesion, it is the lesion in the posterior-temporal component of the head of the humerus. Okay, this is Hill-Sachs and this is Pankhurst. This is very important for NEET PG and next kind of competitive exams. And yes, what is the treatment in case of TUPS? Surgery, arthroplastic surgery is the treatment of choice. Now let's come to AMBRI. In case of AMBRI, it is atraumatic. It is not due to trauma. It is mostly due to connective tissue disorders such as Marfan's, Ehlers-Danlos. Okay, and it is multi-directional. So it is not limited. It's not unidirectional just in case of TUPS. It is multi-directional. It can occur in any direction. It is bilateral, whereas TUPS is unilateral. This is bilateral. And R, it needs rehabilitation. So the basic difference is that in case of TUPS, the patient is anxious and he is afraid to complete an arc of motion because he will get dislocate his arm. But in case of AMBRI, the patient has to dislocate his arm in order to complete the arc of motion. So rehabilitation is required in case of AMBRI. And finally, the treatment is internal capsular closure. In case of AMBRI, there should be internal capsular closure. This sums up the case of shoulder dislocation. So we have discussed in detail about the various components and aspects and management of shoulder dislocation. Thanks for watching. Keep supporting.